I'm going to talk about, so this is the overview of the talk. I'm first going to talk about the risk factors and disease modifiers which are associated with hepatocellular carcinoma. Next, I'll look at the strategies to decrease the risk of HCC development. And finally, I'll talk about surveillance for HCC in high-risk groups. Next slide. So let's take on risk factors and disease modifiers associated with HCC. Next slide. So any chronic GI tissue injury leads to inflammation and or fibrosis, and that increases the risk of cancer. And this is not particularly specific for the GI tract, but if we just focus on so it can happen in other organ systems as well. But looking at the GI tract, for example, in esophagus, if there is long history of acid reflux and there is Barrett's development, that provides the environment for development of esophageal cancer. Similarly, in the stomach, if there is atrophic gastritis or focal intestinal metaplasia, that creates a risk for gastric cancer development. In chronic pancreatitis, particularly chronic calcific pancreatitis, there is risk of pancreatic cancer. Inflammation of the biliary tree is manifested as primary sclerosing cholangitis, creates a risk for development of cholangiocarcinoma. Patients with long-standing celiac disease have risk for small bowel adenocarcinoma. And similarly, those with ulcerative colitis have risk of colon cancer. So there is a pattern of moving from chronic injury to inflammation and fibrosis that leads to an environment which is conducive for carcinogenesis. So in liver, if there is chronic inflammation or chronic hepatitis, particularly if there is significant fibrosis associated with it, that creates a risk for hepatocellular carcinoma. Next slide. So let's look, for example, at hepatitis B. Hepatitis B is actually the most important cause of liver cancer worldwide. So if you look at the top figure there, the dark areas are the ones where there is highest incidence of chronic hepatitis B infection. And those are basically China and sub-Saharan Africa, and also Alaska. And if you look at the bottom figure, you can sort of overlap it. The bottom figure shows about hepatocellular carcinoma incidence. So there is a strong correlation between incidence of chronic hepatitis B and the incidence of hepatocellular carcinoma, which sort of, gives you an idea about the linkage between the two. Next slide. Now, hepatitis C is the second leading cause of hepatocellular carcinoma worldwide. If you go from the top to the bottom on the figure on the right, patients who are exposed to hepatitis C, about 75 to 80% will develop chronic infection. Over a period of 2 to 3 decades, 10 to 20% end up developing cirrhosis. And those are the patients, not only those with cirrhosis, but those who have extensive fibrosis, what we refer to as bridging fibrosis, they are at risk of hepatocellular carcinoma. And that is estimated to be at the rate of 1 to 4% per year. Next slide. Now, more recently, we have seen NASH emerging as the most important risk factor for hepatocellular carcinoma. So again, it's the same pattern of chronic injury. So moving from NASH, meaning there is fatty infiltration with some inflammation. So there is healthy liver to non-alcoholic fatty liver at the top. You can see that. To the right, there is non-alcoholic steatohepatitis, which means not only there is fatty infiltration, there is inflammation associated with it. Then this progresses to NASH with fibrosis, cirrhosis, and that provides risk for hepatocellular carcinoma. Next slide. So the risk of hepatocellular carcinoma may vary by etiology of liver disease. As I mentioned earlier, chronic hepatitis C and B were noted to be the most important causes for chronic liver disease and hepatocellular carcinoma risk in the US. Now, more recent studies, so this figure on the right is from the Veteran Health Administration, from the national database. As you can see, the patients with NAFLD are at much higher risk of hepatocellular carcinoma compared to controls. Next slide. So there are multiple disease modifiers that impact HCC development. So I already mentioned cirrhosis and advanced fibrosis, but in addition to that, there are other disease modifiers, including race and ethnicity, smoking, alcohol use, viral load in the case of hepatitis B, obesity and diabetes, insulin resistance, gut dysbiosis, and inflammation. Next slide. Cirrhosis is the most important risk factor for HCC. So if you look at the figure on the left, and you see these trend lines indicating cumulative risk with months of follow-up. So with time, the risk of development of cumulative risk of development of HCC is highest in patients with cirrhosis. In this particular study, there was a combination of those with cirrhosis and elevated alpha-fetoprotein level were at the highest risk, which is not surprising. While those with just chronic hepatitis had a much lower risk. So indicative of liver cirrhosis being the most important risk factor for HCC. However, there are patients who may develop HCC without cirrhosis. So on the right is a study that compares patients who have hepatitis C on the left to those with NASH on the right. And as you can see, in patients with hepatitis C, less than 10% of the patients who have HCC, they don't have cirrhosis. So cirrhosis in hepatocellular carcinoma in patients with hepatitis C develop in 10% of the cases, there is no associated cirrhosis. But when you compare to patients with NASH, there are almost 20 to 25% of the patients with hepatocellular carcinoma who don't have cirrhosis. So cirrhosis is obviously a very important risk factor for HCC, but there are patients without cirrhosis, particularly in NASH, who may develop hepatocellular carcinoma. Next slide. Race and ethnicity is also an important risk factor. So this slide shows the trend in HCC incidence between 2000 and 2012. So at the top are the Asian Pacific group that has the highest risk of hepatocellular carcinoma, followed by Hispanics. Next slide. Now, how about viral load? Now, this was particularly demonstrated in chronic hepatitis B. So these are, on the left, are all patients. The lines actually show you different groups of patients with different level of viral load. And this, with time, it shows you the cumulative incidence of HCC. As you can see, the top line, the dark black line, are the patients who had greater than 1 million copies of HBV DNA in their blood. And the bottom lines actually show you those with a lesser degree of HBV DNA level. And as you can see, those with the highest level of HBV DNA were at the highest cumulative incidence of HCC. Now, on the right, if this is the subgroup of patients who were not cirrhotic, they have normal ALT and they were HBe antigen negative. Now, the significance of HBe antigen is that in negativity, it usually indicates a quiescent disease. However, there is a subgroup of patients who may have high DNA level who are HBe antigen negative, and they have a sort of a mutation in hepatitis B that causes E antigen negativity. So even in this subgroup of patients, those with the highest level of DNA level had the highest risk of hepatocellular carcinoma. So this slide, actually, this study showed the association between viral load and risk of HCC. Next slide, please. Now, how about alcohol and smoking? So in the left is a study that looked at 5-year cumulative incidence rate of HCC according to alcohol intake and viral eradication. The top line are those who were drinking alcohol and had HCV eradication. And the bottom line are the ones who were not drinking alcohol and also had HCV eradication. And as you can see, there is a significant difference in the cumulative rate of HCC between those two groups, indicating that alcohol can independently increase the risk of HCC development. And these are patients who had underlying cirrhosis. And similarly, this again shows another study, the risk of HCC according to the cumulative alcohol consumption in terms of grams per year. And the odd ratio of HCC development is higher among those with a higher level of alcohol consumption. And the same applies to tobacco consumption in terms of pack years. So both alcohol and tobacco increase the risk of HCC development. Next slide, please. Now, how about obesity? This has been shown to be a risk factor of HCC. And so in this study, if you, there is different age groups, you can see overweight, obese, and if you look at the cases on the left, compare it to the controls on the right, those with obesity, the bars are much longer compared to the controls, indicating obesity as a risk factor for HCC. Next slide, please. So this is all within the group of patients who have metabolic syndrome. Metabolic syndrome is the combination of obesity, insulin resistance as manifested with type 2 diabetes, dyslipidemia, and hypertension. So this is a study looking at HOMA2-IR, which is a measure of insulin resistance. And as you can see, on the left are patients with hepatitis B, and this shows the cumulative incidence of hepatocellular carcinoma. So those with a higher level of insulin resistance had higher risk of HCC. This also applies to patients with hepatitis C on the right. Again, if you look at patients who developed hepatocellular carcinoma, they had a much higher level of HOMA2-IR with a cutoff greater than 4, indicating insulin resistance being a risk factor for HCC in both patients with hepatitis B and HCV. Next slide. How about gut microbiota? And this has emerged as an important risk factor. This is an association between gut microbiota that is measured by Simpson's Index of Diversity. So on the left side, you can see the extreme left figure, there are healthy controls and cirrhosis. So there is a difference in diversity with a lower diversity index in patients with cirrhosis. On the right, you can see the patients with in yellow who are the healthy controls, green cirrhosis with no hepatocellular carcinoma, and red cirrhosis with hepatocellular carcinoma. And as you can see, there is a difference in diversity with lowest diversity among patients with cirrhosis and hepatocellular carcinoma. Next slide, please. Let's talk about strategies to decrease the risk of HCC development. Next slide. So, as Dr. Monga indicated, you have normal, if you look at the top bar, normal hepatocyte moving along with subclinical molecular histological neoplasia. Then you have diagnosis of primary HCC, and then there is secondary HCC. And this correlates with liver disease progression from chronic hepatitis, advanced fibrosis, and cirrhosis. So the question is, what sort of strategies we can apply to prevent HCC development at different stages of the disease process? So the primary prevention would be before chronic hepatitis actually develops. Secondary, when there is chronic hepatitis, advanced fibrosis and cirrhosis, and perhaps there is early development of HCC. And tertiary, once the patient has already developed HCC, treated, and what sort of strategies we can follow to prevent further development, recurrence, or new HCC development. So the number of strategies which can potentially be applied, antiviral therapies, anti-inflammatory treatments, anti-fibrotic treatments, metabolic disease treatment, and molecular targeted therapies. Next slide. So in terms of primary prevention, this is for individuals, healthy individuals who have not yet developed liver disease. What can be done? So one of the preventive modalities that have been looked at is just diet. And as you can see, when you move from vegetable diet to animal fat, dairy fat, and combination of animal and dairy fat, the hazard ratio for HCC development goes up. So there is merit in limiting the amount of animal and dairy fat. Next slide. This is the alternative health eating index. And as you can see on the right is the highest quality diet, and that is associated with lower HCC risk. And I mean, there is information available for alternative healthy eating index, and essentially lower added sugars, lower fat, more grains, legumes, nuts, etc. Next slide. Now, one of the greatest success in HCC prevention and control of hepatitis was observed in Taiwan. So Taiwan introduced hepatitis B vaccination in 1984. And over the years, I mean, this slide only goes up to 1993, but that led to a dramatic drop in HCC development and HCC death rates in children who are 0 to 9 years of age at the time of vaccination. Next slide. Secondary prevention in terms of those who already have hepatitis B. So if you treat hepatitis B, there is a lower risk for HCC development. This is again a study from Taiwan looking at almost 22,000 patients. The top line are the patients who were not treated for hepatitis B, the bottom line who underwent treatment for hepatitis B, and there is a significant difference in the cumulative incidence of HCC among patients who underwent treatment for hepatitis B. So suppression of virus or viral eradication in hepatitis B reduces the risk of HCC. Next slide. And the same is true for hepatitis C. This is a study by Kamal et al. And actually, we were also involved in another study. I don't have the paper to show you, and with similar results. So this is a study of patients who had hepatitis C, who underwent treatment for hepatitis C. And unlike hepatitis B, in hepatitis C, we can actually achieve viral eradication. And as you can see, there is a significant difference in HCC incidence among patients who achieved a sustained virologic response compared to those who were unable to achieve a sustained virologic response. Next slide. So going back to the point about both hepatitis B or HCV, suppression. So first of all, there is a association between HBV viral level and HCV development. But if you treat or suppress HBV virus or you eradicate hepatitis C, both of those strategies result in reduction in HCC risk. Now, how about diabetes and alcohol? So this is a study looking at those patients who actually had a sustained virologic response to hepatitis C therapy. So hepatitis C, in a way, and looking at other factors that can influence risk of HCC in addition to hepatitis C. And as you can see, two factors actually stand out. One is diabetes and another is alcohol. So patients with diabetes and those with continued alcohol use had a higher risk of HCC development. Next slide. So how about, is there a prospect for chemoprevention in hepatitis C? Can we use something, can we give a medicine that will prevent the development of hepatitis C? And two drugs stand out. One group of drugs are statins, which are widely used, and the other is aspirin. Next slide, please. So there are multiple ongoing trials of HCC chemo prevention with a number of agents, including statins, vitamin D, herbal medications. Next slide. And this is a study from Swedish registry looking at 50,000 patients with hepatitis B and HCV. Patients who used aspirin, low dose, were at a lower risk for HCC. Next slide. This study looked at statins. So there are patients on the left with liver cirrhosis at the top line, those without liver cirrhosis on the right, and at the bottom are patients with diabetes and without diabetes. And as you can see, that the adjusted odds ratio for HCC was much lower in patients who ever used statins. So this points towards possible beneficial effect of a statin in prevention of HCC. Next slide. Similarly, metformin use has been associated with decreased risk of HCC. Next slide. Coffee consumption is associated with decreased risk. Next slide. Vitamin D levels, higher vitamin D levels have lower risk. Next slide. Okay, so I talked about multiple associations in terms of risk factor for HCC. Most of these are associations, and there are prospective studies probably needed to confirm those observations. So what are the strategies in terms of those who are at higher risk of HCC? What can we do in terms of early detection of HCC at a stage where we can make a difference in terms of their outcome? Next slide. So this study looked at this question, and it looks like that if we perform surveillance, it leads to early detection. This is a meta-analysis looking at a number of different studies. And it not only surveillance improves early detection, it can lead to a higher level of curative therapy, resulting in improved 3-year survival. Next slide. So in view of those findings, here are the AASLD guidelines for HCC surveillance. Who should be screened for HCC? So patients with cirrhosis needs to be screened and should undergo surveillance for HCC. And there are a number of groups. Cirrhosis may be from hepatitis C, B, alcohol, NASH, primary biliary cirrhosis, hemochromatosis, and alpha-1 antitrypsin deficiency, or any other cause of cirrhosis. All those patients need to undergo surveillance for HCC. Now, how about patients who actually do not have cirrhosis, but they have significant risk factors for HCC development? So this group includes patients with hepatitis B, an Asian male older than 40 years, an Asian female older than 50 years, patients with hepatitis B at any age with family history of HCC, and Black and Africans with hepatitis B greater than 20 years. So these patients need to undergo surveillance in the absence of cirrhosis. That is with or without cirrhosis. Next slide. What is the best strategy for HCC surveillance? This is a meta-analysis looking at 13,000 patients. So if we use ultrasound alone, the sensitivity is 45%. When we combine it with ultrasound and alpha-fetoprotein level, the sensitivity improves to 63%. Next slide. Once we could use ultrasound, another modality we often use is either an ultrasound-based. This is from the LIRADS classification of liver nodules. When you look at liver nodules, there are certain features of liver nodules on ultrasound, as well as on CT and MRI. And based on those findings, you can determine whether it's a definite HCC, which we term as LIRADS 5, or those with indeterminate or benign lesions. Next slide, please. We have to be conscious about harms with surveillance strategies, because if we see a nodule, we think it's HCC, then it creates a chain of events, may lead to biopsy. Biopsy can cause complications, may even have death. So we have to be conscious about the fact that the question is, can HCC surveillance cause harm to patients? So what it makes us think is that perhaps we need to have better modalities for HCC surveillance. We're using ultrasound and alpha-fetoprotein, but as I showed you, the sensitivity is 63%. And then there are patients with false positives who undergo further treatment and interventions, which can cause potential harm. Next slide. So this will be the future. We need newer biomarkers for HCC surveillance. We need deep learning based on MRI images, and clinical data are being developed to improve our surveillance results. Next slide. So in conclusion, cirrhosis from any cause and chronic HBV infection without cirrhosis are the most important risk factors for hepatocellular carcinoma. There are potentially modifiable risk factors that can decrease the risk of HCC development. Chemoprevention of HCC may help decrease the risk of HCC in high-risk subgroups. Currently, ultrasound with alpha-fetoprotein every 6 months is the preferred surveillance method for HCC, but better surveillance strategies are needed. Thank you.